This is a lecture on the respiratory system. So as we get started into this respiratory system, we're going to target this system the way we've done in the past. We're going to look at the who, the what, the where, the when, the why, and the how. So we're going to start right with the functions. Exactly what is going on here? How does it accomplish it? Who is involved in accomplishing these functions? And off the bat, if we just brainstorm a little bit and start thinking about the nose, the mouth, the trachea, the lungs, as some of the major players here. We think about muscles, the diaphragm, as being one of those major muscles to help us breathe. So right off the bat, our first function that we're going to talk about is to provide extensive surface area for gas exchange. And this is going to occur between the air and the blood, and specifically the little structures that are going to help facilitate exchange are going to be our alveoli. We'll talk about these again in a little bit. So again, massive surface area. We need to optimize the amount of gas, oxygen, carbon dioxide that is loading and unloading at a pulmonary level and a systemic level. So providing a huge surface area is going to be key to maximize the amount of gas exchange that occurs. Second is pretty straightforward. We need to move air to and from the lungs. That's going to help exchange these gases. So again, move air to and from those exchange surfaces via our respiratory passageways, nose, mouth, pharynx, trachea, etc. Secondly, we have a huge function of protection. We have to protect those delicate alveoli, those delicate respiratory membranes. And what do we do? How can we protect them? We have to protect them against 1, dehydration, 2, temperature changes, 3, pathogens. So this brings us all the way back to A&P1, where we talked about the epithelium and the trachea, that pseudostratified columnar epithelium with those 2 modifications, the goblet cells and the cilia. And look, it's essentially like fly paper. The goblet cells are secreting mucus. That cilia is power stroking, brooming that mucus out once it catches and traps all that dust and that debris, again protecting these delicate surfaces. We could look at dehydration and temperature changes. If we have any runners out there, it's harder to run in the winter, in the cold weather, where the air is colder and drier. It constricts arterioles and makes these delicate moist membranes a little more dry, harder to move and become compliant and with every breath that you take. So it's easier in the spring and summer when the weather is warmer and the air is hydrated, because it facilitates movement of these gases through these membranes. So all these structures that we have inside our nose, if you go back to those nasal conchae that we dealt with AP1, those bony shelves, those bony folds that were highly vascularized. Every time you breathe in through your nose, those conchae are hydrating the air and warming it, again facilitating the exchanging of gases. So we get a lot of protection here, a lot of facilitation. The fourth function we see is producing sound. So we have our vocal cords, our vocal folds, that's going to help us to allow us to speak, sing, and produce noise. And we'll talk about that as we move through this presentation. And then the last thing is back to our special senses lecture with facilitating the olfactory system, facilitating the detection of olfactory stimuli with that little patch of mucus and those olfactory sensory receptors supported in that, so that every time we breathe in, those odorants are dissolving in that mucus patch, allowing and facilitating olfaction. The next thing we're going to talk about is the actual act of breathing and respiration. We're going to divvy these systems up into a couple processes, and we're going to cover some basic definitions. First and foremost, we need to understand what respiration is. Respiration is defined quite simply as the exchange of gases between the atmosphere, the air we're breathing, and the blood in our body and the cells that are facilitating and assisting in the exchange of those gases. In order for respiration to occur, we need a combination of 3 basic processes. Number 1, and most broadly, is going to be ventilation. This is simply the act of breathing, the movement of air in and out of the lungs. The second two are going to be lumped together, external respiration and internal respiration. Basically, external respiration is going to be the exchange of gases at a pulmonary level. So we're talking about what's occurring in those alveoli at a lung level. The last process we look at is internal respiration. And again, this is going to be at a tissue level. So again, same thing like what's happening at the lung level. We talk about what's occurring at the capillary beds, at our tissues, okay? And exactly what's occurring with exchange of gases and nutrients. Well, for respiration, we'll be dealing more so with gases. And then, as usual, we bring us back to the cardiovascular system, because this is going to be one of those key players that's going to help assist the respiratory system by being the vesicle, the vehicle for transporting those gases from the lungs to all the different parts of the body. And again, we think back to those different circuits, systemic circuit versus pulmonary circuit. This is what we're kind of talking about here. Now we can go on and look at the structures of the respiratory system. We're going to break this system down into two categories, a structural classification and a functional classification. When we classify the respiratory system structurally, we're talking about a division into two parts, an upper respiratory system and a lower respiratory system. The upper respiratory system is pretty much going to be everything from essentially the neck up, right? So we talk about the nose, the mouth, and we're going to isolate the larynx as kind of our go-between, our division. So this is where we're going to divide the upper respiratory into the lower respiratory. So pretty much everything below the larynx is going to be our lower respiratory system. And we'll look at the players in these two divisions in a little bit. Functionally, we talk about the two different functional zones of the respiratory system. We deal with conducting zone. Right? And its name tells us exactly what it does. It's conducting. It's moving air from the outside environment to inside the lungs. Now we can take a peek forward and start saying, well, okay, well, we know we're moving air from outside the body to inside the body. How do we do this? This is what should be working through your head right now. What is the processes, or how does the air move? And if we go back to what we talked about actually when we were in class last, that most of these systems are going to be driven under one premise, and that premise is going to be pressure. So again, here we are again, these are pressure-driven systems. So pressure differentials, and we'll look at those in a little bit, but again, peek ahead and keep it in the back of your mind. Those pressure differentials are going to help conduct air through these passageways. The second zone is going to be our respiratory zone. Now, what differentiates conducting for respiratory is the conducting zone is just movement. It's dead space. We're just moving air from one area to another. The respiratory zone is going to be just that. It's going to be the actual exchange of gases on a cardiovascular, on a cell, on a tissue level. Okay, and specifically in the lungs. So we'll look at those components in a little bit. This slide is going to give us a general overview of the respiratory system, specifically the structures, and we can see a couple things here. We see that we have in the thoracic cavity a left and right lung, right? So two lungs, one on each side. We see that the heart is located in between them in this mediastinal cavity. We see a cardiac notch where that heart is going to take up some space on that left side. And we can see a little bit some of the fissures, the separations of these lobes on the lung. So we're going to talk about lobes of the lungs. We'll talk about the general anatomy of this gross anatomy. From here, we can look at some other structures, the trachea, and you should see and recognize that we have the thyroid sitting here. And then as we go to the right picture, we look at the head. Right? We see our nose, our internal nasal cavity. We see these sinuses, right? These are resonating chambers. These are chambers that are going to help us produce sound. And if you think about the structure and functions of these and how they interfere with sound production, think about when you're sick and you have a sinus infection, or if your nose is stuffed up, does this affect and change your voice? And the answer is yes, okay, because we're affecting these resonating chambers. We have the pharynx. Okay, we're going to talk about the three different divisions of the pharynx, our larynx, and our trachea. And then it bifurcates, it splits, and we'll talk about each of these splits into our lungs in a little bit. And then the diaphragm would be resting right under here. That's going to assist in changing the pressures Not by much, but changing it enough to get us to breathe in and breathe out. We're going to elaborate on the respiratory system anatomy, and we're going to look at a picture on the next slide that's going to walk us through all these specific structures. Again, differentiating and separating the upper respiratory system, which consists of the nose, the pharynx, and all those associated structures within them, to the lower respiratory system, again, that larynx being that landmark that separates these two systems, including the trachea, the bronchi, and the lungs. Turbinid, that. So with this picture, we can identify the different parts of the upper respiratory system, and we look at the nose and all its associated structure. So we start right here with the external nares, and because there's always balance in biology, if we have an external nares, we're going to have an internal nares, and that internal nares is going to be located right behind, it's that space right behind those nasal concha. Remember, we have our superior, middle, and inferior nasal concha. These turbinates, right, they're called turbinates, these folds, are going to be super important for, when you breathe in and air comes into your nose, it's going to make that air swirl around here. And what this does is it allows, remember, these are highly vascularized. If you go back to when we looked at the skull and we looked at the inferior nasal concha and the middle nasal concha, and we saw that they were very fragile, very holy. That's because they're highly vascularized. That's going to allow air, when it moves in through here, to be warmed, to be filtered, to be humidified before traveling down into the delicate respiratory passageways. We're also going to see a funnel-shaped structure, and again, that funnel here is going to be our pharynx. And our pharynx is going to be divided into three basic regions. We have the nasal portion, right? So we have our nasopharynx. We're going to have the portion by our mouth. It's going to be the oropharynx. And as we move down into the larynx region, we're going to hit our laryngopharynx. So a couple more structures to look at. Obviously, we have the tongue. The tongue is going to help allow us to make sound and enunciate. A couple tonsils to point out. We have our lingual tonsil. We're going to have our palatine tonsil. And we're going to have our adenoids tonsils, or pharyngeal tonsils. Okay, and here's a palatine tonsil right here. Okay, a couple more important structures are kind of over my drawing, but right here, this little heart or leaf-shaped structure of cartilage, it is the epiglottis, and this epiglottis plays an important role, as every time you swallow, this thing kind of slams down and covers the trachea, preventing any food or water or drink aspirating down into your lungs. And then macrostructures, we have the esophagus laying flattened behind the trachea. If we start on the outside and work our way in, we start with the cartilaginous framework of the nose. And again, you see pretty straightforward, if we go back to AP1, our small little nasal bone here, right? So we have our nasal bone with the frontal bone and the maxilla. It's giving us our bony framework. And then we have cartilage. The cartilage is going to give us a cartilaginous framework. We get two lateral nasal cartilages, a septal cartilage. So this is what separates the left and right portion. Is going to link up to those two bones, the vomer and the perpendicular plate of the ethmoid that forms that nasal septum. We get these minor and major alar cartilages, again, making that outside bony framework of your nostrils. And then we get some dense fibrous connective tissue in through here with some adipose, again, framing and outlining that nostril cavity. Here's a repeat in the picture that we talked about a few slides ago. And again, I like this one because if you look down here, this bottom portion, it's going to give you a coloration of the three different parts of our funnel as we move through our pharynx, right? Our nasopharynx, our oropharynx, and our laryngopharynx. This slide takes us into a mid-sagittal frontal cut to look at those nasal conchae and all the meatuses, the superior, middle, and inferior portions underneath those conchae, like those little cavities. So again, these are turbinates. So when you breathe in, these help to humidify and warm the air as it's swirling in and around these nasal folds. So if we look at it mid-sagittally, you can see our superior nasal concha followed by our middle nasal concha with our inferior nasal concha. And accordingly, we have our little meatai, the meatus, inferior nasal meatus, middle nasal meatus, and superior nasal meatus, so that space underneath that bony shelf. The frontal section is good because I like that it shows all the space around here, that the air is going to swirl in those meatuses, in and around those spaces around those nasal conchae, and then bordering them are resonating chambers, right? We have our sinuses on the side over here that's going to help us resonate bone-filled cavities, the maxillary sinus, right and left. For our surface anatomy of the nose, it's pretty straightforward. Where the nose really attaches, where that nasal bone is, right here, is going to be our root. We can look at the apex of the nose. This is the tip of our nose. That brings us to the bridge. And our external nares, number 4. This is where air is going to be moving in every time we breathe in. We can look at the pharynx. Again, this kind of zooms in and focuses just on that funnel-shaped passageway. Its function, again, is going to be to move air and food through the tube or from the mouth down into, well, for food, for deglutition will be the esophagus. For breathing, respiration, it would be the trachea. It's also going to act as that resonating chamber for speech. It's going to house our tonsils, again, these rings of lymphatic tissue that's going to serve an important immunological function to protect, surveil against foreign invaders as we breathe in and as we swallow. And again, the colorations of this tube is key, right? We see the nasopharynx and that nasal cavity. We can see its outline, its margin. We have the oropharynx, again, its margin. And then all the way down to the larynx for the laryngopharynx for the third part of this funnel. So now we're going to zoom in and look at a real important structure here. It's the larynx. It's also known as the voice box. And it's going to be a landmark, again, separating the upper respiratory from the lower respiratory zones. We're going to get the connection of that funnel-shaped pharynx down through the trachea. But if you notice, we see a lot of blue here. This blue is going to represent cartilage, so a huge cartilaginous framework. And we see these large plates, and if you look at the anterior aspect versus the posterior aspect, you see that the thyroid cartilage right here is going to be pretty large as compared to the cricoid cartilage in the back here, which is going to be equally large. So we get that impression that these large cartilaginous plates, which by the way is hyaline cartilage, is going to serve a function, important function. And the function is to protect what's inside it. So we say, well, what's inside it? And the answer is, well, your vocal folds, your voice box, right? So this is what's allowing for the production of sounds. And we get some of these other parts, components of this cartilaginous framework, like our corniculate cartilage and our arytenoid cartilages. These are these claw-like structures up here that are going to help move and bounce around to help tighten, loosen, open and close, pull on those true vocal folds to produce sound. Now, we're going to isolate and talk about each one. So we're going to go ahead and erase the marks we just made and be able to draw on this all over again and get back into some of these things. So let's start with some of our cartilaginous plates. The first one that we're going to look at is the thyroid cartilage right here. This is one of the largest plates we have in our larynx. It is made up of hyaline cartilage, and this little prominence right here we're going to see, because this is important. In males, the thyroid cartilage is a little bit bigger, and the reason why is because when males hit puberty and they get this surge of testosterone, this plate tends to grow a lot bigger in males, more so than in females. Not saying that females aren't surging testosterone, they are just not as much as their male counterpart. So females do have this thyroid cartilage. Again, it's just not as large as it is in males because of they're lacking that huge surge of testosterone. The next cartilaginous plate from the anterior view, we're going to outline it over here because the thyroid is kind of in the way, thyroid cartilage being one. Cricoid cartilage number 2, and if we move to the posterior aspect, you see it is just as large in back as or pretty close as to what the thyroid cartilage is in the anterior aspect. And again, it's protecting, it's guarding, it's protecting those folds inside. So we look at the cricoid cartilage, and I want to point out a region, a space, and we're going to outline it in a different color. We're going to make it red, and we're going to talk about why this region is so important. There's a ligament here. It's called the cricothyroid ligament. From a clinical perspective, if somebody were to, let's say, we'll use a scenario, but again, don't try this at home, with my little disclaimer. If you ever watched a movie and somebody's choking and somebody jumps in onto them and slices their throat and inserts a straw, this is kind of what we're talking about. If you were going to insert a trach tube into the neck, this is the place that you're going to go. This is the largest space. This gap right here is the largest space that we can access the trachea. If you look at all the spaces, and we'll look on this posterior view, between these C-shaped rings, it's relatively small. It's really hard to get any type of device, respirator, ventilator, anything through here. So we use this space between the cricothyroid ligament. So we'll run through a little scenario. Again, we're not going to ever, hopefully, do this in real life. So let's erase what we've done so we can look at a new scenario and talk about exactly how we would do an emergency tracheotomy. So again, from a clinical perspective, if you were, let's just say again, don't try this at home, was my disclaimer, but if you were in a restaurant and somebody were choking and the Heimlich didn't work and you're trying to save somebody's life, you would feel for, number one, the thyroid cartilage. From there, we would go on, so number one, my pen's not working, here we go, number one, and then we feel for the next big bump, which is the cricoid cartilage, and then we feel for the space in between right here. We will then take a scalpel, make an incision from right to left. We will stick our finger into the space. Remember, this is not going to be bleeding a lot. This is not a highly vascularized area. From there, we're going to stick our finger through that incision we just made, open it up, and insert a tube so that that person can reestablish breathing, bypassing that food blockage that would be up here. Okay, so a quick little tidbit on how to save somebody's life in such a scenario. Okay, so sorry for our digression. Let's erase this, and we're going to get back into our structures of our larynx. So we go back to our cartilage and we look at these two finger-like. It keeps picking, I apologize. I'm working through this app. It keeps picking. Let's erase that. And let's go to our other pen tool. It's a little more fine. And we go to this little cartilage here. And we'll see that there's two parts. It looks like a finger, a claw. Okay. What this claw is going to do, again, composed of two cartilage, a corniculate and an arytenoid, and we're going to go and look at an internal aspect. And we'll see that these two claws essentially wiggle back and forth. And what they do is they move, vibrate those true vocal folds to help produce sound. The next cartilages that we're going to talk about are these right here. And I'm going to outline a few for you. They are the C-shaped rings, so these incomplete cartilaginous rings, again, all hyaline cartilage that wrap around the trachea, giving it rigidity, giving that tube structure so it doesn't collapse on itself, which would make it next to impossible to breathe. And they're going to move all the way down the entire length of the trachea. But again, notice they are incomplete. They do not wrap all the way around. And the reason why is because there's another tube back here that lies flat against it. It is the esophagus. So when this tube, when the structure was developed, it was pretty important to make it incomplete. And the reason why is every time you swallow, that bolus of food travels essentially down and in between this space. If these rings were completely connected, completely around, rigid circle, you would be feeling these speed bumps every time you swallow. Da-dunk, 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 da-dunk. It's like trying to drive on the highway at 40 miles, 50 miles an hour and putting a speed bump every 20 feet. So we removed them. We didn't, but the evolution of this tube removed them and made them incomplete, knowing and realizing, recognizing that there's another tube down here that's passing food through, and to make it easier, it made it flat. The last cartilaginous plate we're going to talk about is right here. This heart or leaf-shaped plate. It is known as the epiglottis. If we go back to the epiglottis, remember that we do have taste buds on this structure. We know that it is not. It is one of the only cartilaginous plates that is not. All these are hyaline, right? Not hyaline, but elastic cartilage, okay? And this thing's going to slam down and open when we're swallowing to protect that trachea, to make sure that we do not aspirate food down that tube. Looking at the larynx from a different view, we can look at it mid-sagittally, looking on in. We can see our vestibular folds. These are known as our false vocal folds. And we see our true vocal folds right here. Right? This is what's being contained within that larynx, and when they move, when they vibrate, they're going to produce sound. So a couple more, or at least one more, because we only see half of this, pieces of cartilage that we weren't able to identify before in that view are the cuneiform cartilage, okay? And it's going to be posterior to our craniculate and our arytenoids, that finger-like structure, that claw-like structure that we saw from the side. But again, I like this view because we get to see that massive thyroid cartilage and the cricoid cartilage, again, kind of protecting, encasing these vocal folds. Our next slide takes us through structures of voice production. So we're going to look at this picture to kind of look at some of these structures and details, examine how they work and how they accomplish their goal of phonation. So if we look at the glottis, we see the glottis is made up of 3 parts. Our true vocal folds, right? These are the folds that are actually producing sound. We have the rhimoglottis. This is the space between the true and false vocal folds. And the third one, our vestibular folds, are also known as our false vocal folds. Now, real quick, just to go through, we're not going to spend too much time talking about what they do, but the long and the short is that our true vocal folds work by vibrating, and by vibrating, they're going to expel air and produce sound. The vestibular folds do one of 2 things. When they are abducted, they will be open. When they are adducted, they are closed. So when they're closed here versus open here, the function of the vestibular folds is going to be pretty simple, to keep air trapped down in that lung area, as well as preventing anything from closing through, essentially closing off the glottis. And then just some ancillary structures. We have the tongue up here, followed by the epiglottis right here. As we continue our journey down our trachea, we leave the larynx, and we could start looking at the actual anatomy of the trachea and look at its function. So our picture in our lower left corner does a pretty nice job of showing you that incomplete cartilaginous ring as it comes around, those C-shaped rings. Look how wide open that space is maintained. The esophagus, right behind it, flattened tube. This is what's going to allow for swallowing, deglutition. And off on the left, you can see the the picture of these 2 tubes next to each other. On the right, we get a nice scanning electron microscope picture of the cell. Remember, the cell is pseudostratified columnar with cilia. So again, that cilia is this red hair-like structure you're seeing, and you got a goblet cell right here. That cilia and those goblet cells are going to work together to essentially make flypaper, trap that dust, that dirt, and the debris, and broom it up, power stroke it out to prevent it from getting to those delicate respiratory surfaces. As we continue down this tube, we hit the superior border of the 5th thoracic vertebra, and we get our first bifurcation. So the trachea is going to branch. It's going to branch into the right primary bronchus and the left primary bronchus. So the right primary bronchus is going to enter the right lung, and the left primary bronchus is going to enter the left lung. Now, interesting note, I want you to pay attention to this anatomy here. remember this is where the heart goes, and we see a defect in the left lung, this cardiac notch. And we're going to get to gross anatomy of the lungs, but again, pay quick note that that left lung has 2 lobes, and the right lung, all fissures aside, has 3, which means the right lung is going to be a little bit bigger. Now, when we talk about this first bifurcation, our primary bronchus, I want you to look at something. Now, I'm just going to erase this. I'm going to erase everything. We're going to kind of start over again. Now, again, I want you to pay note and pay attention to our trachea moving its way down. And again, that first bifurcation, first thing to notice, we get this enlarged little cartilaginous pad. It is shaped like a little bikini bottom. This is called the carina, so we see that word right here. And this is an important part because this is where we get our last cough reflex. Okay, and what this does when you get that tickle in your throat that makes you cough, we are getting a stimulation of something, either dust, dirt, debris, or an allergen, or something that made its way through all these other protective mechanisms down here in the trachea and fired off that last cough reflex. Okay, now let's go back to our primary bronchi, and we're going to erase this again so we can see. So the next question, if we look at a clinical significance or clinical part of this, we're going to look at the right versus the left. Now, if you were to aspirate something, a piece of food or something down the trachea, the question is which side of our bronchi, our primary bronchi, would it most likely lodge, the right or the left? Well, then the next question would be, well, if it's going to lodge in one, that means one of these bifurcations is going to be steeper and wider, and the other is going to be more flat and narrower. So the question is, which one is steeper, which one is wider, and which one is more flat? Well, the answer is this one right here. Our right side is going to be steeper and wider. So we're going to diagrammatically draw that for you. It's going to go outside the boundary. And the left side, we're going to exaggerate this a little bit. Let's draw this a little bit differently. The left side is going to be flatter and narrower. And then the question that I always get is why? Why is the left side flatter and narrower? Why is the right side wider and steeper? If something gets aspirated, it's most likely going to get stuck here on the right side, which is wider and steeper. And the answer is pretty simple. Again, remember that defect, that cardiac notch, the heart. Because the heart is located on the left side, anatomically, the first bifurcation of this bronchus, that primary bronchus, has to account for that. So it grows narrower and flatter. Whereas the right side of the lungs, 3 lobes, 2 fissures, larger of our 2 lungs, does not have anything in the way, no heart in the way, so that primary bronchus can be steeper and wider. So again, if we were to aspirate something, more likely than not, it will get stuck right here on the right side. As we continue down our bronchi and leave that first bifurcation, we're going to assign a name to each split thereafter, major split thereafter. And there's different terminology we can use. Our book bounces between primary bronchi, main bronchi, secondary bronchi, lobar. You can use whatever. I prefer using the numbers because it makes it a little more easier to memorize. So if we follow our way down, we leave the branching of the bronchial tree, we have our trachea, we have our main bronchus. We already said that it was our primary. We then branch again, gives us our lobar bronchi, which we can call our secondary bronchus or bronchi. We hit our next set of smaller branches. Now we're getting smaller and smaller. As we move our way down, the diameter of these branches are getting smaller and smaller. We continue on to our segmental branch. We're going to call it our tertiary bronchi. From there, we hit our bronchioles, and it leads to our terminal bronchioles. And this is really where the conducting zone, all that dead space that's just moving air, not really doing anything else other than just moving air, definitely no gas exchange here. Okay, so it's just a conducting zone, ends right at this terminal bronchiole. We can put it all together and look at the bronchi. Again, we start at the trachea. We go to our main or primary bronchus. We're going to star the trachea. Then we go main or primary, lobar and segmental, so secondary, tertiary, followed by our terminal bronchioles and conducting zone. From there, we hit our respiratory zone, which gives us our respiratory bronchioles, and now we're into our alveolar ducts and our alveolar sacs with our alveoli. Now, if we think of it like this, think about a bunch of grapes. When you go to the grocery store and you buy a bunch of grapes, it comes in a little pouch, and that pouch has holes that those grapes are able to breathe. That pouch is going to represent our alveolar capillary bed, the capillaries that are surrounding these little alveoli. And each of these little alveoli represents the grapes. Our alveolar ducts are going to be the little stems that connect those grapes together. And then as we move our way towards the respiratory bronchioles, this would be that large stem that you would grab on the outside of the bag as it leads to our separate set of grapes. We're going to look at this again, so don't worry too much right now. Now that we've finished with the tube and the bronchi and the bronchioles that lead to those respiratory structures, now we can look at our lungs and talk about how they're organized, how they develop, and what they look like. Now, we know we have two lungs, right? We keep this pretty simple. We're going to call it 1 and 2. Let's see, I'm not a big fan of that 1. So let's go back. 1 and 2. Now, if we look at our left lung, we notice we have 2 lobes separated by 1 fissure. We have our superior lobe and our inferior lobe. When we look at our fissure, look at its angle. It is on a 45-degree angle, so it is an oblique fissure. The notch that we see here is our cardiac notch. This is where the heart is going to sit. And again, basic anatomy, if you think about a pyramid where we have the apex on top and the base on the bottom, the lung is no different. Now, I'm just going to erase all this work so we could keep looking at some other structures here. Okay, now we can go on to our left lung. I'm sorry, our right lung. We just did our left lung. Look at our right lung. Same thing. 1 lobe, 2 lobes, 3 lobes. We have an oblique fissure and now a horizontal fissure. Now, naming the lobes works superior, middle, and inferior. Okay, and below we see our diaphragm here, waiting to do some work to get us either inspiring or expiring. So the next question is, how do we protect the lungs? So similarly to how we protected the heart with the pericardium and how we protect the small intestines with all our peritoneal folds, we're dealing with something called a pleural membrane. So we have 2 layers like any other serous membrane, a outer parietal layer, an inner visceral layer that's actually fused to the lung tissue with a pleural cavity in between. We're going to look a little more closely at the lobes and fissures of the lungs, but I want to use this picture to show one thing. We just got finished talking about the pleural membrane surrounding the lungs, and the question I always get, especially in lab when we look at these bell jar models to represent pressure differentials and how our lungs inflate and deflate, we don't often talk about the separation of the pleura. So the question that I usually ask is there one pleural membrane surrounding both lungs, or does each lung have its own pleural membrane? And this picture does a good job in explaining that. Each lung has its own pleural membrane. And the question is why? Why did we not just make one membrane, make it easy, surround both lungs, and call it a wrap? Well, the answer is in predation, is in protection, is in surviving danger and damage. So if you think about it like this, if we had one pleural membrane surrounding the entire lung, right, that pleural membrane is setting up a pressure differential from what's outside to what's inside the body. In order to keep this pressure differential, it keeps air moving from a positive pressure to a negative pressure. And again, when we say positive and negative, we're talking about atmospheric pressure, right? So 760 millimeters of mercury. And we're adjusting this either plus or minus. And by affecting this pressure, by bringing it down or up, this is essentially going to give us a breathing in phenomena or an exhaling phenomena. And we'll elaborate on this, so don't really worry yet. But keep in mind that we need to maintain a pressure differential. If you were to pop this, so let's say you got stabbed, shot, or if we go back to early development, a saber-toothed tiger bit us on our right side of our chest cavity, all the air would escape, which would bring pressure down to zero, no longer have a pressure differential, which means our lungs would, and you're probably saying it out loud, collapse. Now, evolution, nature, survival of the fittest was pretty smart when it developed this system. It separated them. So now let's erase all my markings here. Let's get rid of this horrible idea of one pleural membrane around both lungs. And let's look at the new scenario. So we'll keep our 760 millimeters of mercury to remind us that we do have atmospheric pressure on top of us. Now we have each lung encased in its own pleural membrane. Now, saber-toothed tiger comes through, we get shot or stabbed on one lung, all the air escapes. This lung, our left lung, collapses. And because we have a separate, protected right lung, this one would not collapse. The right lung would not collapse. So this is a genius system, a genius way of protecting our lungs, protecting our ability to breathe when damage is incurred. So yes, two separate pleural membranes, one around each lung. Again, smart way to engineer this system to make sure that we keep the integrity of our lungs intact if one were to get damaged. So this slide we already went through a little bit, but let's elaborate on a couple parts. We're going to look at the lobes and fissure of the lung. So if you look at the picture, we see, and we should be able to tell left or right without any labels. On this side, we see one oblique fissure, two lobes. So this right away tells us that this is our left lung. Here, 1, 2, 3, two fissures. This is our right lung, oblique, horizontal, superior, middle, and inferior lobe. Now, if you look on the inside, I want you to pay note to this structure. We're going to see these words, hilus, hilum, again and again, or hilum, however, potato, however you want to say it, again and again. Anytime we have a capsular structure, we're going to see this in the kidney. We saw this in the spleen. We get an invagination of the structure to allow for blood vessels, nerves, lymphatics. Here we're going to have our primary bronchus moving in here, so a tube. This is going to be called a hilum. It's also known as our root. Okay. Just a few more outlines. We drew a triangle on our a couple slides ago to show the apex and the base. Well, here's our apex on top and the base, so the point and the broad portion. The next series of events that we're going to talk about is in our respiratory zone. So remember, when the conducting zone ends at the terminal bronchioles, our respiratory zone begins. We're going to start with the respiratory bronchioles, lead to our alveolar ducts, to our alveolar sacs, and our alveoli. So again, we think about that bag of grape analogy, where we start with the respiratory bronchiole, that primary stem for the grapes. We go to the little stems that connect all the grapes, the bunch of grapes to each grape individually. So this is a nice little analogy to help us understand how this system is set up. Now we're going to focus in on those alveoli. And go to our next slide, we're going to look at what the system looks like and how the lymphatic system and the arteries and veins intertwine. So a couple things I want to point out first. Remember that we're coming from and to the lungs. So in our pulmonary trunk, when we did cardiovascular last week or a couple weeks ago, we saw that this was that weird phenomena where arteries were blue and veins were red. Well, remember that this carries through into this respiratory zone as well. So if you notice right here in our pulmonary arteriole, it's blue. And right here, our pulmonary venule, it's red. This is signifying that blood that's been deoxygenated coming from the heart that's going to now be oxygenated through these pulmonary capillaries surrounding these bunch of grapes. That was synonymous with that little net meshy bag that was surrounding our bunches of grapes that we just bought at the store. Okay, and then it gets oxygenated and we leave going back to the heart via our pulmonary venule to our pulmonary veins into the left atrium. Inside, if we cut open into this alveolar sac, and we see all our little groups of alveoli, in the middle right here and here and here, we get series of, we'll color them in just so they differentiate from our other circles, we get these series of alveolar ducts, again, that little stem that leads to each individual grape. And on top, we could box it in, our terminal bronchial, as we move on down to the respiratory bronchial, alveolar ducts, alveolar sacs to alveoli. Now I want you to note, look at here. We have our visceral pleura. Remember, we're surrounding our tissue with the serous membrane. Here is that serous membrane. It's that innermost layer of the pleura. Next, we're going to talk about the alveoli. Each alveolus is made up of two different types of cells. We have type 1 pneumocytes and type 2 pneumocytes. Their job is going to be to diffuse oxygen and carbon dioxide in and out of those capillaries. So we're going to be loading oxygen into the blood and unloading CO2. If we look here, our type 2 alveolar cell, they're also called septal cells. Their job is super important. They're going to make something called a surfactant, and we'll talk about what that is in a little bit. So hang tight. We have a respiratory membrane as we work our way down. We'll talk about why that's important and why it has to be somewhat elastic. We have our type 1 alveolar cell, type 1 pneumocyte. This is what the majority of cells in the alveoli are going to be made up with, close to 92 to 96%. And then we have another cell that is called an alveolar macrophage. It's a dust cell, and it does exactly what its name implies. It's going to sit here. It's a fixed macrophage. Its job is to wait any piece of dust, dirt, debris that happened to make it past all those other protective mechanisms in the nose, in the trachea, inside our bronchus, will now be gobbled up and eaten here by this dust cell. We will look at each alveolar cell separately. Here's our first type 1 pneumocyte. It is going to make up about 97% of that alveolar surface. It's an extremely attenuated cell, and what this means is it's going to be extremely thin, and that's important. Not only will it be thin, but it's going to be more hollow. And if you think about the function of these cells, they're simple squamous epithelium, really thin, hollow. Its function is to exchange gases. So from an engineering standpoint, from a standpoint where we're designing the perfect form and function here, it makes sense that if we're going to be exchanging gases, we make the space, the distance that it travels really short. So we're making the A to B really short, and we're not muddling it with a ton of fluid and a ton of organelles and a ton of stuff. So we make these cells really thin and somewhat hollow. It maximizes and optimizes gas exchange. Okay? So again, their main role is to provide a barrier of minimal thickness so that it's readily permeable to gases such as oxygen and carbon dioxide. The second type of alveolar cell is our type 2 pneumocyte, also known as a septal cell, has a super important job. It produces a surfactant. A surfactant is a mixture of proteins and lipids, and its job is to reduce the surface tension in that alveoli fluid. Essentially what it's doing is it's making and maintaining the wetness inside those alveoli. And this is going to be super important because if you think about what surfactant does, we'll use an analogy of a slip and slide, right? So reducing friction. So if you want to get a slip and slide working well, you add water, right? This is normal anatomy, normal wetness within the alveoli. If you want to go super fast, even faster on that slip and slide, what would you do? You'd add soap. By adding soap, this is a surfactant, we are reducing friction by increasing the availability for us to move faster. Well, instead of moving fast here, the surfactant is going to help keep the alveoli from sticking to each other and collapsing. So this is important. If you think about, or even if you've ever taken a piece of saran wrap off of a container that's been in the fridge and there's some moisture on it and it's stuck together, right? It's next to impossible to pull apart. Well, a similar phenomena occurs here. And what we see is that this surfactant, when we breathe in and breathe out, these alveoli expand and contract a little bit, and they can collapse on each other. So to prevent them from sticking together, are these type 2 septal cells, these type 2 pneumocytes, produce this oily secretion, again, to prevent these alveoli from sticking together. Now, from a clinical perspective, we'll talk about why this knowledge of what surfactant does is so important, because fetus usually doesn't start producing their alveolar cells, or type 2 pneumocytes aren't really active till about 24 to 28 weeks. Now, this is important, especially if you have babies born prematurely, or even if you have babies born after that 28-week mark and are put on a ventilator. You'll see that most doctors are going to prescribe a nebulized surfactant through that ventilator, so that that baby has that ability to breathe easier without allowing or preventing those alveoli from collapsing on tops of each other and causing those lungs to collapse, which would be a terminal condition for that child. So important to understand when surfactant is made, and clinically, especially for preemies, why we would administer synthetic surfactant to assist in the ease in which that baby could breathe. The next part of the system we're going to talk about is that respiratory membrane that we circled before. It's composed of that layer of type 1 and type 2 pneumocytes. We're going to have those alveolar dust cells or macrophages in that alveolar wall as well. We have an epithelial basement membrane here that's going to underlie that alveolar wall, followed by a capillary basement membrane. And this is typically going to be fused to the epithelium basement membrane. Following that, we're going to have a layer of endothelium. This is the capillary endothelium that is going to permit the movement of gases in and out from the alveoli to the capillary. Blood supply to the lungs is pretty straightforward. We covered this in lecture and lab a few weeks ago. So blood enters the lungs through the pulmonary arteries, this is pulmonary circulation, and the bronchial arteries, systemic circulation. Blood exits the lungs through our pulmonary veins and the bronchial veins. The next phenomenon we have to talk about is ventilation-perfusion coupling. Now, this is a little bit interesting, well, somewhat confusing too, if we think about it separately. In respiratory physiology, the ventilation-perfusion ratio is going to be a ratio that we use to look at the efficiency and adequacy of the matching of two specific variables, and those variables are ventilation and perfusion. Now, in order to understand what that is, we have to know the definitions. Ventilation is going to be the amount of air that actually reaches the alveoli. When we talk about perfusion, we talk about the amount of blood that reaches the alveoli via the capillaries. Now, when we put that together and talk about perfusion coupling, we get ventilation-perfusion coupling, which basically means that more blood flows past functional alveoli than past non-functional alveoli. So then the question is, how does the body respond? So when we get hypoxia, low oxygen levels, right? So vasoconstriction is going to occur in response to hypoxia. We're diverting blood from poorly ventilated areas to well-ventilated areas. And again, if you think about those two variables, ventilation and perfusion, this makes sense. So if our body is detecting hypoxia, low oxygen concentrations, we're going to divert blood from the areas that aren't getting much oxygen to the blood and divert it to areas that are delivering a lot of oxygen, or well-ventilated areas. So an interesting phenomenon that our body has the ability to divert blood from areas of low ventilation to high ventilation, of poorly ventilated areas to well-ventilated areas, depending on detected conditions such as hypoxia. Table 23.1 does a pretty good job in breaking apart everything we've talked about: structure, nose, pharynx, larynx, trachea, the type of epithelium we find in there, whether it has a modification of cilia or goblet cells, and what special features. For example, we see numerous hairs for filtration, conchae for making air turbid, olfaction for smell. Okay, and we can continue down for auditory tube, tonsils. See what the oropharynx is, the passageway for both air and food, okay, and drink. And then we look at the laryngopharynx, passageway for both air and food and drink. We notice no goblet cells, no cilia, right? It is in the nasopharynx that we're really utilizing these modifications to protect, filter. And then we do our larynx. We see the cilia, yes and no, no above folds, yes below folds. Again, filtering when we get past this larynx. Epithelium, pseudostratified ciliated columnar inside the trachea. Notice in the mouth and all the way through the pharynx, stratified squamous. Except for the respiratory region, we have ciliated columnar. And then we have stratified squamous in the oropharynx, laryngopharynx. Back in the nose, ciliated. We're filtering, nose filtering, not so much through the mouth. Continuing with 23.1, look at our bronchi, primary bronchus, ciliated pseudostratified columnar, following through secondary, tertiary. When we hit the bronchioles, we change epithelium. Simple columnar, and then the terminal bronchioles, simple columnar. And then when we hit the respiratory, because remember we're exchanging gas, we're no longer, this is all conducting zone. When we hit the respiratory zone, so again, let's write this in, conducting. This is respiratory. We see a switch over to our modified epithelium. Simple squamous epithelium, simple squamous epithelium, simple squamous epithelium. Again, exchanging gases. Gas exchange, gas exchange, gas exchange. That's our key here. So we continue to look at the three basic steps involved in respiration. Now, as we talk about this process, I want you to keep in back of your mind that this is a pressure-driven system. Remember we said a few slides ago that atmospheric pressure is 760 millimeters of mercury. So everything above us is exerting a pressure on our body equivalent to 760 millimeters of mercury. Now, we said before that it's a small plus or minus differential in pressure, which brings us to how do we increase or decrease the pressure? And the answer is in muscular contractions. So if we look right here, we have the diaphragm. This contracting or relaxing is going to give us a pressure change. That pressure change is going to give us breathing. So if we think about some laws, we look at Boyle's law, and we're going to look at another slide to explain this pretty quickly. And what Boyle's law says is that there's an inverse relationship between pressure, that's a B, not a P, let me erase that, between pressure and volume. So what that means is pressure's high, volume's going to be low. So if volume's low, that means the lungs are shrinking, which means that we are exhaling. And if pressure's low, that means, you're probably shouting it out now, volume is high. If volume is high, the lungs are expanding. This is going to be inhaling. So again, keep this in the back of your mind. We're going to walk through these steps and examine this phenomena. So at rest, we start right here. The diaphragm's relaxed. Alveolar pressure is equal to atmospheric pressure, which means inside is 760. Alveolar pressure is 760, and atmospheric pressure is 760. Now, intrapleural pressure is going to be a little bit lower than atmospheric pressure. This is the pressure between the pleura. It's about 756 millimeters of mercury. And this is not really going to change much. It's going to go a little bit lower to 754 with inhalation, and then even with exhalation, it's going to be, if we look at exhalation, it's going to be maintained at 756. So we're going to kick these numbers out and really talk about alveolar pressure. Now, let's change alveolar pressure. The diaphragm is going to contract down, so it pulls down. The external intercostals are going to contract. The chest cavity is going to expand, and alveolar pressure is going to drop to 758. So if we go back to this area here, right, and we say, well, pressure went down, that means volume is going up. So we look right here, volume is going up. Air is going to rush from an area of high pressure to low pressure, 758. So that gives us inhalation. Okay, but this is quiet breathing, also known as eupnea. This is not during a forced inspiration. If we wanted to breathe more deeply, we use secondary respiratory muscles, muscles like the scalenes, okay? Muscles like the sternocleidomastoid, that's going to help to pull up on rib 1, expand the chest, giving an even greater drop in alveolar pressure, which brings even more air into the lungs. So notice we're using secondary accessory muscles other than the diaphragm to increase the pressure differential. Now again, for quiet breathing, again, we're talking 300 to 500 mils of air, not a lot of air. It's what you're doing right now, sitting still, not really exercising, not really running or walking. You're breathing at a normal, relaxed pace. So for exhalation, let's look. The diaphragm relaxes, it domes back up, pressure rises. Alveolar pressure goes from 758 in inhalation to 762. Now we go back to Boyle's law. If pressure goes up, we expect volume to go down, and that's exactly what happens. The chest and lungs are going to recoil elastically. The chest cavity contracts. Alveolar pressure increases to 762. This causes a flow of air from high to low, which is 760, and air is going to move out. Now, if we have to forcibly blow out candles or blow a leaf or a hair out of our eyes, we need to produce more force. We need to increase the strength of our exhalation. And what we're going to use is, again, just like forced inspiration, where you can use accessory, secondary respiratory muscles. These muscles are going to include our internal intercostals. Now, if you take a deep breath in and blow out as hard as you can in your seat, you'll feel your abdominal muscles contract and compress. So we use our abdominal muscles too to force an expiration. Okay. We can focus in on pulmonary ventilation, and we can define it as air flows between the atmosphere and the alveoli of the lungs because of these pressure differentials that we just talked about. And these pressure differentials are set up by those muscle contractions and relaxation. We give two phenomena, inhalation and exhalation. We've thrown these words around, but we never really put it to slide. Now, this picture is going to give us a pretty good outline of Boyle's law. And basically we said that there's an inverse relationship between pressure and volume. Pressure goes up, volume goes down. And we see in our picture here, here's our piston. Volume's at 1 liter, pressure's at 1 liter. We increase pressure to 2 atmospheres, okay? That gives us a decrease in volume to ½ liter. Okay, so this is just a diagrammatic explanation of Boyle's law. Our next slide is going to show us the way our muscles work during inhalation and exhalation. We can use this black line to kind of split into inhalation on this side and exhalation on this side. And all the muscles we just outlined look with inhalation. Diaphragm's pulling down, it's contracting. Our external intercostals are elevating those ribs, opening up that rib cage. Sternocleidomastoid, up. Scalenes, up, pulling up on rib 1, right? Elevating our rib cage. Take a deep breath in. Feel your shoulders lift up. Feel your rib cage open. These are all secondary muscles of inhalation. Muscles of exhalation. Look at those internal intercostals before we were external. Internal, pulling down. Compression of the abdomen. Pulling of our internal obliques and our transverse abdominis. Right? And you could feel this. If you blow out as hard as you can feel your rectus abdominis compressing down, shrinking that chest cavity, forcing a lot of air out of your body. Again, we look mid-sagittally, or at least sagittally, to see the position of the diaphragm during exhalation, domed up. pulling down, contracting its way during inhalation. Another review of our pressure changes. So it's a slide that we just looked at. So it's in summary. We're not going to go over it again, but know that it is there for your assistance. The next thing we need to talk about are factors affecting pulmonary ventilation. So remember, we have that ventilation perfusion phenomena. We're talking about moving of air, not really oxygenating. So factors that affect our ability to move air from the outside to our lungs. So we have a couple things here. Number one, we have surface tension. This is an inwardly directed force in the alveoli, which must be overcome to expand the lungs during each inspiration. Now, we have a simple solution to this. We resolve surface tension by using surfactant. The problem is if we smoke or vape, or as we get older, we interfere with surfactant production and or our ability for these alveoli to overcome this force, and we have a hard time moving air through our lungs. The second is going to be elastic recoil, and what happens here is we decreasing the size of the alveoli during expiration. So every time you take a breath in and out, these alveoli are expanding, contracting, expanding, contracting, expanding, contracting. And again, as we get older, we lose elasticity. We talked about the properties of elastic connective tissue and arteries, and we said that as we get older, as we put an undue pressure or a chronic undue pressure on the system, these elastic fibers start wearing out and they get tired and they lose their elasticity. As we get older, our lungs, there's no exception here. It does the exact same thing. This is why look to your grandparents, your great-grandparents, and as they have trouble walking up stairways and going for long walks because they're losing these factors, these three things that are affecting pulmonary ventilation: the ability to control surface tension, they're losing that elastic recoil, and lastly, they're losing compliance, right? When you're young, you have great compliance. It's the ease with which your lungs and thoracic wall can expand. Assuming all things equal, assuming that you're not a smoker or a vapor or, over the age of, we could go 60, 70, 80, right? These are all things that decrease compliance. You have pretty good compliance, ease at which your lungs and thoracic wall can be expanded. Again, other factors that can affect this: asthma. Asthma can affect compliance, right? We get bronchial or bronchi constriction, right? So the smooth muscle in this tube will constrict down, or inflammation can cause a harder time to ventilate, to move air into these lungs, right? So compliance, again, the ease with which the lungs and thoracic wall can expand. We can examine some breathing patterns and respiratory movements. We'll go one by one through each of these and try to explain. Some of them you should be familiar with. Eupnea is normal breathing. I threw this term out a couple slides ago. This is quiet breathing, normal breaths, that 300 to 500 milliliters of air that you're moving in and out of your lungs right now while at rest. Apnea, you've probably heard of this. It's been all over the media, news, commercials lately. Sleep apnea. It's a condition that affects a huge number of Americans today due to obesity and other underlying issues. It is a cessation of breathing as a result of usually a blockage of that respiratory passageway. Your tongue can push back their excess weight from obesity on the neck, on the pharynx, etc. Usually treated with a CPAP machine. We have dyspnea, and dyspnea is shortness of breath. And basically, there's a bunch of things that can cause this. You can get this with exercise, altitude, believe it or not, tight clothing, even mental health disorders like panic attacks, or if you have anxiety disorder, this can include and could cause dyspnea or shortness of breath. Tachypnea is fast breathing, again due to exercise. Panic attacks can cause you to breathe quickly. Hyperventilating would be a good example of tachypnea. Costal breathing, this is using your intercostal muscles to assist in breathing. This tends to be problematic with asthmatics and children. So we have viruses like RSV, any type of respiratory virus that affects or causes inflammation in our bronchi. And what that does is it makes it very difficult to breathe. And as a result, as that diaphragm tires out, so then we get in the bottom here, diaphragmatic breathing. That diaphragm is responsible for breathing. We enter into a secondary muscle breathing. We use scalenes, we use the sternocleidomastoid, and we use our costals, our intercostals. The problem with this is that these muscles weren't meant to sustain breath. They're there for quick bursts of maximum inhalation, maximum exhalation, but not sustained breathing. So they tire pretty quickly. So for children, and you'll see when children suffer from asthma, they'll engage, once that diaphragm gets tired, they'll engage in costal breathing, and they'll pull in through their neck. Sometimes they look like bullfrogs. It could come out 3-4 inches from their neck. It appears that way. And then their stomach will be bowing out as their stomach muscles are helping them breathe, and then their ribs will be elevating and compressing, this exaggerated motion like they're forcing a breath in and out. Could be pretty bad for children. This is why they would seek medical attention immediately if this were to happen. Table 23.2 goes through all our different modified breathing methods like coughing, sneezing, sighing, yawning, sobbing, crying, laughing, hiccuping, a Valsalva maneuver, and pressurizing the middle ear. You've probably done some of these. If you close your nose and your mouth and then try to force some air out of your lungs, that helps equalize pressure in the middle ear. Valsalva maneuver, this is forced exhalation against a closed rim of glottitis, as what happens like if you're straining while pooping. Okay, this can force air against those closed vestibular folds. Laughing, same basic movement as crying. The rhythm of the movements and the facial muscle expressions usually differ. So we can go into sobbing, yawning. Again, yawning, a deep inhalation through a widely open mouth. Why does this happen? Well, believe it or not, somebody else yawning can cause this. Sleepiness, a lack of oxygen detected to the brain. Although the precise reason why this really happens, we really don't know. Sneezing, so this is pretty interesting. Spasmodic contraction of muscles for exhalation that forcibly expels air through the nose and mouth. There is a genetic disorder called Achu syndrome. I bet you most of you have it if you've ever found yourself looking at a bright light or staring up towards the sun to elicit a sneeze. You suffer from this condition. You can look it up on your own time. It is called Achu syndrome. This is going to be our last slide for this portion of our lecture. We're going to look at lung volumes and capacities. This is something you're going to look at in your lab manual and that biopack theory lesson. This is something we would have done in lab, which would have been used biopack to measure some lung volumes and capacities. I'm going to point out a few things here. Use your lab book and manual to work through the calculations, but we have some definitions here. We see words like tidal volume, right? And you should know the definitions. And we'll say, well, tidal volume is the amount of air that's being inspired or expired during eupnea, right? During quiet breathing, okay? And then we can take it further and we say, okay, what is inspiratory reserve volume? And we say, well, here's this here, and it's a pretty large number, 3,100 milliliters, right? It's the additional amount of air, if you look at the definition, the additional amount of air that can be inhaled after a normal tidal volume. So we end the tidal volume, we take in as much air as we can. And again, between male and female, we look at about 2,000 to 3,000 milliliters. The next thing we have to look at is going to be expiratory reserve volume. Now this number is much lower, 700 for females, 1,200 for males. And we say, well, what is this? So this is the amount of extra air. So we're talking about after a tidal volume. So we're talking about right here, after a tidal volume, that we can exhale. So the above normal breath, exhale during a forceful breath out. So that means you breathe out and you blow out even further. So it's really a small number. So it goes from here to here. And we see that female is about 700 and then male is about 1,200. So again, if we had to define it, it's the amount of air that we can forcibly expel after a tidal volume. So this is hard because even during lab, when we run through these exercises and we say to you, okay, you have to think about not thinking about thinking about breathing, right? It sounds confusing because it really is confusing. And you have to say, okay, I'm going to breathe out normally without breathing in forcibly. And then after I breathe out normally, try to force out as much air as you can. It is really hard, but if you do it successfully, you'll see that it is only a small amount of air. The next thing we're going to look at for volume is right here, residual volume. Now this is an interesting number. It's about 1,100 to 1,200 milliliters of air. It is this space. So at the end of an ERV, expiratory reserve volume, all the way down to 0, your body maintains this amount of air in it at all given time. You cannot expel all this air. You cannot get rid of it. Your body will not allow you. And the reason why goes back to when we talked about the pleural cavity and popping one of them and letting all the air out. Leaving this residual volume in our lung cavity keeps our pressure differential. When you pop a lung, this residual volume escapes. When it escapes, the lung cavity collapses. The next thing we're going to talk about outside of volumes is going to be capacities. Now when we look at capacities, we'll start with inspiratory capacity, and it's again a relatively large number, 2,400 mils for females, 3,600 mils for males. This is the volume of air that could be inspired, so breathed in, following a normal, quiet expiration. If you had to do a calculation, you would take tidal volume, so if we see our arrow here, and we just summate these two regions, it's tidal volume plus IRV. Okay, and this is a capacity, not volume. The next one we're going to look at is functional residual capacity. And we see this is a decent number, 1,800 mils to 2,400 mils. And again, if we look over to the volumes, we can start figuring out what we have to add. Residual volume plus ERV gives us FRC. So what this is the volume of air present in the lungs at the end of a passive expiration. Notice we start at the bottom of a tidal volume. Okay? At functional residual capacity, the opposing elastic recoil forces of the lung, so here we go with those elastic recoil forces, and the elastic recoil forces of the chest wall are going to be in equilibrium. This means that there's no exertion by the diaphragm or any other respiratory muscles. So this is functional residual capacity. That brings us to vital capacity, and this is going to be one of our largest numbers. And this is, if you've ever been to a doctor for asthma or breathing issues and you had to take that tube, put it in your mouth, and they told you to take a deep a breath in as you can and blow out as hard as you can. What they're measuring is vital capacity. And again, vital capacity is good because it diminishes with asthmatics, it diminishes with smokers and vapors. So basically, if you look at the definition, it's the greatest volume of air that can be expelled or expired from the lungs after taking the deepest breath possible. And you see it's one of our largest numbers, 3,100 mils for females to 4,800 mils for males. TLC, unfortunately, it does not stand for total loving tender loving care here. This is total lung capacity, and for females 4,200 mils and about 6,000 mils for males, and this takes into account everything: IRV plus tidal volume plus ERV plus residual volume to get our total lung capacity.